We have now finished discussing the 4 integrated processes that will be covered on your examination. We are now beginning the safe and effective environment, coordinated care and safety, and infection control portion of the examination. The practical vocational nurse collaborates with healthcare team members to facilitate effective client care. They must be able to provide information about advance directives, advocate for client rights and needs, promote client self-advocacy, assign client care and/or related tasks, for example, assistive personnel or LPN/VN, involve client in care decision-making, contribute to the development and/or update of the client plan of care, for example, client preferences, review current information, participate as a member of an interdisciplinary team, recognize and report staff conflict, participate in staff education, for example, in-services and continued competency, use data from various sources in making clinical decisions, monitor activities of assistive personnel, maintain client confidentiality, provide for privacy needs, follow up with client after discharge, participate in client discharge or transfer, provide and receive reports, organize and prioritize care for assigned group of clients, practice in a manner consistent with Code of Ethics for nurses, participate in the client consent process, use information technology in client care, receive and process healthcare provider orders, recognize task assignment you are not prepared to perform and seek assistance, respond to the unsafe practice of a healthcare provider, for example, intervene or report, follow regulation policy for reporting specific issues, for example, abuse, neglect, gunshot wound, or communicable disease, provide care within the legal scope of practice, participate in quality improvement QI activity, for example, collecting data or serving on QI committee, apply evidence-based practice when providing care, participate in client data collection and referral, participate in providing cost-effective care. Specific content in this section includes advance directives, advocacy, assignment delegation and supervision, case management, client rights, collaboration with interdisciplinary team, concepts of management, confidentiality information security, continuity of care, establishing priorities, ethical practice, informed consent, information technology, legal rights and responsibilities, performance improvement, quality improvement, and referrals. Welcome to the Coordinated Care section of this course. As we move from line to line of the NCLEX blueprint, we will begin with Advance Directives. Advance Directives. Providing information about Advance Directives. The Patient Self-Determination Act was passed by the U.S. Congress in 1990. It gives Americans the right to make decisions relating to future care and treatments when the person is no longer able to give informed consent and/or the refusal of care and treatments because the person is incapacitated to do so. These decisions are documented with an advance directive and/or made by the legally appointed healthcare proxy or surrogate according to this national law. At times, the advance directive is referred to as a living will. The healthcare proxy or surrogate is also referred to as the healthcare power of attorney and the durable power of attorney for healthcare. The durable power of attorney for healthcare is separate and distinct from any durable power of attorney for financial matters. This same law mandates public education and the fact that all hospitals, including psychiatric facilities, and all health insurance plans have state law-specific policies and procedures relating to advance directives. The Uniform Determination of Death Act, approved by most states in our union, provides some guidance in terms of end-of-life decisions. This act defines death as either the irreversible cessation of respiratory and circulatory functions or the irreversible cessation of all brain functions including brain stem function. The 5 wishes developed with a grant from the Robert Wood Johnson Foundation, should be addressed and considered in the living will or advance directive. These wishes include the patient's choices in relationship to 1. Medical care and treatments that the patient wants and does not want. 2. Pain management and the promotion of comfort. 3. Who they want to make decisions for them about their care when they are no longer able to make these decisions. 4. Things that they want their loved ones to know. And 5. How one wants to be treated and cared for by others. Although advance directives and durable powers of attorney for healthcare decisions vary slightly among the states, there are far more similarities than there are minor differences. Nonetheless, all people should follow the laws and the regulations of their primary state of residence. All state regulations are consistent with the U.S. Patient Self-Determination Act of 1990, as just discussed. Although advance directives and durable powers of attorney for healthcare decisions can be done with a lawyer, they can also be done by the individual patient without a lawyer and/or in collaboration with a representative in a healthcare facility. Advance directives should be as specific as possible. They should also include a complete listing of treatments and aspects of care that the person chooses to have and a complete listing of treatments and aspects of care that the person does not want to have. Perhaps the most common treatments and aspects of care included in advance directives are things like CPR, mechanical ventilation, comfort and pain management decisions, artificial types of nutrition such as feeding tubes, and choices relating to intravenous fluids and medications. Advance directives should be done after considerable thought and reflection by the person making these important end-of-life decisions. Another useful document for decision-making is a values history. Values histories are not legal documents, but they still remain highly important. Values histories reflect a person's beliefs and opinions about basic principles, such as the relief of pain at the end of life. For example, a person may hold the belief that a shorter, pain-free existence is of greater value than a longer life with pain. The person may state that they do not want any cutting on their body. Although specific surgeries may not have been documented in this person's advanced directive, the healthcare surrogate can use these values and discussions when they are making choices for a person who is no longer capable of making decisions relating to things that were not anticipated in the person's advance directive. Reviewing the client's understanding of advance directives, living will, healthcare proxy, and durable power of attorney for healthcare. Nurses, including licensed practical nurses, must determine and verify that the patient fully understands their advance directives, the implications of them, their right to make decisions freely and without coercion, and their right to change them at any time provided they are deemed competent to do so. Nurses must report any misunderstandings and misinformation immediately. Verifying the client's advanced directives status. The licensed practical nurse must review and verify the patient's advance directive status with their first patient contact, because an emergency life-threatening situation, like a cardiac or respiratory arrest, can occur at any time, with little or no time to review these documents at that time. If, for example, the patient has an advance directive to not have CPR, the nurse may administer CPR because they have failed to review the client's advance directive. This CPR, then, is contrary to the patient's wishes. Now we will discuss advocacy. The roles and responsibilities of nurses are vast and diverse. Some of the many nursing roles include advocate, teacher, change agent, caregiver, manager of care, and others. Advocating for client rights and needs. Simply defined, advocacy is standing up for and defending the patient, their access to care and services, and their choices and their rights. In order to fulfill this role, the nurse develops a professional relationship with the patient, which is filled with respect, trust, honesty, equality, patient collaboration, and the active participation of the patient. Promoting client self-advocacy. Client or patient self-advocacy is promoted and facilitated when nurses educate patients and then encourage them to make health-related decisions without any bias, judgments, or criticisms of the patient. Discussing identified treatment options with the patient and respecting the decisions made. When nurses teach patients about treatments and services, they inform the patient about all the treatment options and alternatives, as well as the benefits and risks associated with each. All decisions, regardless of whether the nurse agrees or disagrees with them, are accepted and supported by the nurse in their role as patient advocate. Using interpreters to assist in achieving client understanding. As we discussed earlier in the teaching and learning section, interpreters are used when the patient has a language barrier that impedes their understanding and comprehension. Interpreters are used when the patient has a language barrier that impedes their understanding and comprehension because they speak and understand a foreign language other than English. Next, we will cover client care assignments. Assigning client care and related tasks. The assignment of care to others, including nursing assistants and other licensed practical nurses, is perhaps one of the most important daily decisions that nurse makes. Proper and appropriate assignments facilitate quality care. Improper and inappropriate assignments can lead to poor quality care. Improper and inappropriate assignments can lead to poor quality of care, disappointing outcomes of care, and even legal consequences. Decisions relating to the successful assignments of care are based on the needs of the patient, the skills of the staff, job descriptions, facility policies and procedures, and legal aspects of care such as the state's legal scopes of practice for nurses, nursing assistants, and other members of the nursing team. Comparing the needs of the client to knowledge, skills, and abilities prior to making client care assignments. The 5 rights of delegation that must be used when assigning care to others are the right person, the right task, the right circumstances, the right direction and communication, and the right supervision and evaluation. In other words, the right person must be assigned to the right tasks and jobs under the right circumstances. The nurse who assigns the tasks and jobs must then communicate with and direct the person doing the task or job. The nurse supervises the person and determines whether or not the job was done in the correct, appropriate, safe, and competent manner. Successful assignments depend on closely matching the needs of the patient with the knowledge, skills, and abilities of the staff member. Some client needs are simple, while others are complex. Some needs are acute and/or unpredictable. Others can be chronic and somewhat ongoing and predictable. Still, more patient needs are frequently encountered and others may be far less common. In addition to other considerations and factors, caring for patients with highly complex, unpredictable, and rarely occurring needs should be within the domain of the registered nurse. On the other hand, chronic, predictable, and commonly occurring healthcare needs can be addressed by the licensed practical nurse. The staff member's levels of education, knowledge, skills, abilities, experience, and competencies of staff are also evaluated and matched with the needs of the patients that are included in the group of patients that will be cared for. For example, a patient care technician may not be educated and trained at the same level as a certified nursing assistant. The licensed practical nurse is not trained and educated at the same level as the associate degree registered nurse or the bachelor's degree registered nurse. Based on these differences, care should be assigned according to the level of education of the healthcare provider. Also, staff members differ in terms of their knowledge, skills, abilities, and competencies. A staff member who has just graduated as a certified nursing assistant and a newly graduated licensed practical nurse cannot be expected to perform patient care tasks at the same level of proficiency, skill, and competency as an experienced nursing assistant or licensed practical nurse. It takes time for new graduates to refine the skills that they learned in school. Validated and documented competencies must also be considered prior to assignment of patient care. No aspect of care can be assigned to another until they have documented evidence that they are deemed competent by a registered nurse to do so. For example, a newly hired certified nursing assistant cannot perform bed baths until a supervising registered nurse has observed the certified nursing assistant provide a bed bath and has decided that they are now competent to do this task without direct supervision. Licensed practical nurses must be aware of these scopes of practice and apply these scopes of practice when assigning care, because performing a role that is not included in a person's legal scope of practice is illegal. It is considered practicing nursing or medicine without a license. All assigned care, therefore, must be consistent with the state's legal scope of practice that outlines what each nursing team member can and cannot do. Although there are minor differences among our 50 states in terms of scopes of practice, generally speaking, the scopes of practice for the registered nurse address the phases of the nursing process. These are assessment, diagnosis, planning, implementation, and evaluation. The scopes of practice for the licensed practical nurses include their roles and responsibilities and how they collaborate with the registered nurse and other members of the healthcare team. Here is a portion of the scope of practice for registered nurses in the state of Florida. The practice of professional nursing means the performance of those acts requiring substantial specialized knowledge, judgment, and nursing skill based on applied principles of psychological, biological, physical, and social sciences. These shall include, but not be limited to, 1. The observation, assessment, nursing diagnosis, planning, intervention, and evaluation of care, health teaching and counseling of the ill, injured, or infirm, and the promotion of wellness, maintenance of health, and prevention of illness of others. 2. The administration of medications and treatments as prescribed or authorized by a duly licensed practitioner authorized by the laws of this state to prescribe such medications and treatments. 3. The supervision and teaching of other personnel in the theory and performance of any of the above acts. Here is a portion of the scope of practice for licensed practical nurses in the state of Florida. Florida statutes define practical nursing as the performance of selected acts, including the administration of treatments and medications, in the care of the ill, injured, or infirmed, and the promotion of wellness, maintenance of health, and the prevention of illness of others under the direction of a registered nurse, a licensed physician, a licensed osteopathic physician, a licensed podiatric physician, or a licensed dentist. General guidelines for assigning aspects of care to unlicensed assistive personnel, such as nursing assistants, medical assistants, patient care technicians, and personal care aides, including assigning tasks that are not sterile. These include assigning things like the activities of daily living and assistance with the activities of daily living like bathing, hygiene, and ambulation. They include performing tasks that require standard precautions and medical asepsis, such as measuring urinary output from an indwelling urinary catheter drainage bag, helping the patient with exercises, such as range of motion exercises, taking and documenting vital signs, height and weight, collecting non-sterile specimens, the provision of comfort measures like a back rub, patient transport, and clerical duties including running errands. Established policies and procedures and the components of the staff member's job or position description are also followed for the safe and appropriate assignment of care. For example, a particular facility may have a policy and procedure relating to intravenous fluids and medications that is more restrictive than the state's scope of practice for the licensed practical nurse, when it states that licensed practical nurses can only administer intravenous fluids and not intravenous medications. Organizing information for client assignments. When nurses assign care and aspects of care to others, they should organize the information about the patients and plan care with the person according to priorities. An assignment sheet is often used to organize patient information. These assignment sheets, or forms, typically include the patient's name, room number, and a list of activities of daily living that the person can do independently or with assistance, and other aspects of care, like measuring the patient's intake and output. Providing information to the supervisor when client care assignments have to be changed. Although assignments may be done appropriately at the beginning of the shift, there are times when these assignments have to be changed because the physical or emotional status of one or more patients has changed. For example, Although a certified nursing assistant may have been assigned to provide bathing and hygiene to a client at the beginning of the shift, the nurse may have to reassign the care of this patient to a licensed practical nurse. This can occur when their vital signs, for example, become unstable and/or the patient's level of consciousness significantly changes. All changes in terms of assignments and the rationale or rationales for these changes should be reported to the supervising registered nurse. Client rights. All human beings have intrinsic rights that must remain upheld and supported when the person becomes a patient or a consumer of healthcare services. Some of these rights include the right to dignity, respect, autonomy, decision-making, personal privacy, confidentiality, and the right to actively participate in care and make decisions about the care and services that they want and do not want. The American Hospital Association publishes the Patient's Bill of Rights and Responsibilities and the Resident's Rights and Responsibilities. The American Hospital Association Patient's Bill of Rights and Responsibilities, as part of its patient care partnership, states that the patients have the right to dignity and respect, privacy, confidentiality, competent care, freedom from any and all forms of abuse and neglect, religious and social freedom, accurate bills, complain and be heard and the rights to choose their own doctor or doctors and other healthcare providers, fully know about their medical condition and their treatments, make decisions about their medical care, and control their own finances and personal property. Patients also have responsibilities relating to their behavior and medical care. They are responsible for giving complete information relating to their past and present health concerns and conditions. They are responsible for providing accurate and current health insurance information, actively participating in all aspects of care and treatment, including discharge planning, following the policies and procedures of the particular healthcare facility or agency, and behaving in a manner that is cooperative and considerate of the rights of others. Informing the client of individual rights. As briefly discussed previously with advanced directives, all clients have the right to be fully informed of their individual rights along with the continuum of care. This includes their right to get complete, unbiased information and to make knowledgeable decisions in respect to accepting or rejecting care and services despite the opinions of nurses and other members of the healthcare team, and without any coercion or attempts to manipulate the patient to make another choice or decision. Healthcare has the responsibility to fully inform patients about their rights. This information can be conveyed to the patient orally or with written information and material. Once information about patient rights is conveyed to the patient, it is the responsibility of the nurse and others to ensure that the patient fully understands these rights and is given every opportunity to exercise them. Involving the client in care decision-making. One of the hallmarks of nursing care is patient-centered care. The patient is the center of care, not the nurse, not the doctor, and not others. All disciplines and the services that they provide revolve around the patient's choices, and the patient's needs. For these reasons, patients and significant others, if the patient chooses this participation, should be actively engaged in and participate in all decision-making, all care, and all aspects of care. Intervening if client rights are violated. The best way to prevent any patient rights violations is to follow established policies, procedures, and ethical codes. However, there are some occasions when the nurse may witness a violation of a patient right. When any violations are suspected, it is the nurse's responsibility to stop it if they can and/or report it to the supervising nurse. Suspicions as well as clear facts must be reported so that these violations can be investigated by the proper people. For example, patients have a basic right to be free of all abuse and neglect. If a nurse suspects that another member of the healthcare team may be abusing or neglecting a patient, the nurse is legally mandated to report it. The nurse does not have to be certain that the abuse and/or neglect is actually occurring. All that is needed is a suspicion, and the nurse is mandated to report. Recognizing client right to refuse treatment procedures. As previously discussed, all patients have a right to refuse any treatment or procedure without any undue influence or coercion. All decisions are upheld and respected by the nurse, even when the nurse may think that the decision is unwise and not the right decision. Collaboration with the interdisciplinary team. Broadly described, collaboration is working with others in a collegially and mutually respectful manner. Nurses collaborate with patients, significant others, families, other nurses, and other healthcare providers to solve patient care problems and to provide the optimal quality level of care to the patient or group of patients. Some of the skills that the nurse must possess in order to be an effective and credible collaborator include superior interpersonal and communication skills, respect for others, the ability to establish and maintain trust, critical thinking skills, problem-solving skills, decision-making skills, and the ability to understand and be able to identify the contributions of others that can improve the quality of the patient's care. Identifying the roles and responsibilities of healthcare team members. The titles and numbers of different healthcare team members are vast and diverse. Now, you will learn about some of these team member roles and responsibilities so you can identify and utilize their distinct and unique perspectives and contributions to the plan of care and patient problem solving. The nursing assistant, patient care technician, other titles. A member of the nursing team. These members of the nursing team are unlicensed assistive personnel who assist nurses in the provision of direct and indirect care under the direct supervision of the nurse. They perform non-sterile functions like the provision of and the assistance with the patient's activities of daily living, measuring and recording urinary output and oral intake, helping the patient with exercises such as range of motion exercises, taking and documenting vital signs, measuring patient's height and weight, collecting some specimens, the provision of comfort measures like a back rub, patient transport, and clerical duties including running errands. The licensed practical nurse, a member of the nursing team. Licensed practical nurses are licensed healthcare providers who provide a wide range of nursing services to patients in all kinds of healthcare settings. They work under the supervision of a registered nurse. They perform non-sterile and sterile procedures. They work in structured settings with patients who have predictable and relatively non-complex healthcare problems, including chronic disorders such as heart disease and chronic obstructive pulmonary disease. The registered nurse, a member of the nursing team. Registered nurses are licensed healthcare providers who, unlike licensed practical nurses, are independent practitioners who render nursing care services in a wide variety of healthcare settings. They can work in unstructured environments and with patients who have unpredictable and complex healthcare problems and concerns. The nursing supervisor, a member of the nursing team. Nursing supervisors supervise patient care and the quality of care that is delivered to groups of patients. Depending on the size and complexity of the healthcare setting, supervisors can have many titles, and they may or may not also provide direct nursing care in addition to their supervision of care. Licensed practical nurses report to their nursing supervisors according to the facility's chain of communication and command. For example, they report to their supervising registered nurse, charge nurse, head nurse, then their nursing supervisor, and then to the assistant director of nursing. Following that is the director of nursing or vice president of nursing. Vice president for nursing services, the director of nursing, a member of the nursing team. The vice president for nursing services, also referred to as the director of nursing in some facilities, is the chief nursing officer of the healthcare setting. They are ultimately accountable for all aspects of patient care, the adherence to regulations, and a wide variety of other responsibilities. Nurse clinical specialists, a member of the nursing team. Nursing clinical specialists are master prepared advanced practice registered nurses with an area of specialty who have successfully passed and maintain their American Nurses Credentialing Centers (ANCC) certification as a clinical nurse specialist in a specialty area of practice. Some possible specialties of practice are pediatrics, psychiatric mental health, adult health, and community health. Nurse practitioners, a member of the nursing team. Nurse practitioners, similar to nurse clinical specialists, are master-prepared, advanced practice registered nurses with an area of specialty who have successfully passed and maintained their American Nurses Credentialing Center's ANCC certification as a nurse practitioner in a specialty area of practice. Some possible specialty areas of practice are pediatrics, psychiatric mental health, family health, and community health. Nurse midwives, a member of the nursing team and the obstetrics team. Nurse midwives are advanced practice registered nurses who work with non-risk pregnant women during the pregnancy under the supervision of an obstetrician. Nurse anesthetist, a member of the nursing team and the anesthesia team. Nurse anesthetists are advanced practice registered nurses who work under the supervision of an anesthetist in the provision of all types of anesthesia. Medical doctors. Medical doctors are licensed professionals who provide medical care. Many doctors serve as primary care doctors, but there is a wide variety of medical doctors who perform different roles and who have a specialty area of practice such as cardiology, endocrinology, pulmonary medicine, gastrology, neurology, dermatology, pediatrics, gerontology, ophthalmology, nephrology, psychiatry, and other specialized practices. Physician extenders. Physician extenders work under the direct supervision of a medical doctor. They provide care that is based on protocols and their state legal scopes of practice. They are not, like nurse practitioners, independent practitioners. A physician's assistant is an example of a physician extender. Doctors of osteopathy, DOs. Although doctors of osteopathy are, in some respects, similar to medical doctors, they are also different. Their educational preparation is different, and their licensing, examination, and the scopes of practice are different. They can be found in acute care, long-term care, and community-based healthcare settings. Doctors of osteopathy may also have specialty areas of practice, but most function as primary care doctors. Additionally, they can also provide care, write prescriptions, and perform surgeries. Doctors of chiropractic medicine. Chiropractors work primarily in the community setting. They focus their non-pharmacological treatments of musculoskeletal and neuromuscular disorders, such as scoliosis, chronic headaches, back pain, and neck pain. They too are licensed professionals who have their own state-mandated scope of practice. Dietitians. Dietitians assess, plan, implement, and evaluate interventions, including those relating to dietary needs of those patients who need regular or therapeutic diets. They also provide dietary education and work with other members of the healthcare team when a client has dietary needs secondary to physical disorders such as dysphagia. Physical therapists. Physical therapists are licensed healthcare professionals who assess, plan, implement, and evaluate interventions including those related to the patient's functional abilities in terms of their strength, mobility, balance, gait, coordination, and joint range of motion. They also provide patients with assistive aids like walkers and canes and exercise regimens. Physical therapists practice in all healthcare environments including the home and the community. Similar to occupational therapists, physical therapists practice in all healthcare environments, including the home and the community. Similar to occupational therapists, physical therapists are often found in the rehabilitation and restorative care area of a large acute care or long-term care facility. Occupational therapists. Occupational therapists assess, plan, implement, and evaluate interventions including those that facilitate the patient's ability to achieve their highest possible level of independence in terms of their activities of daily living, such as bathing, grooming, eating, and dressing. They also give patients adaptive devices like special long shoe horns so the patient can put their shoes on, sock pulls so they can independently don socks, special adaptive cutlery to facilitate independent eating, grabbers so the patient can pick up items from the floor, special mouth care tools, and special devices to manipulate buttoning so the person can dress and button their clothing independently. Occupational therapists also assess the home for safety and the need for assistive devices when the patient returns to the home. They may recommend modifications to the home environment such as ramps, grab rails, and handrails to ensure safety and independence. Like physical therapists, occupational therapists practice in all healthcare environments, including the home and the community. Similar to physical therapists, they are often found in the rehabilitation and restorative care area of a large acute care or long-term care facility. Speech therapists. Speech pathologists or therapists assess, diagnose, and treat primarily communication disorders such as aphasia and swallowing disorders such as dysphagia. For example, speech therapists may help patients with the formation of words and speaking when they have an impaired ability to communicate with others using words. This deficit is referred to as expressive aphasia. They also assist the patient with word boards and other electronic devices to facilitate communication. Dysphagia and other swallowing disorders are also assessed, diagnosed, and treated in collaboration with other members of the healthcare team, like nurses, dietitians, and medical doctors. Respiratory therapists. Respiratory therapists, like other members of the healthcare team, collaborate with other disciplines in solving respiratory-related healthcare problems. They draw arterial blood gases, maintain the patient with mechanical ventilation, provide CPAP, BiPAP, incentive spirometry, and intermittent respiratory treatments like IPPB. They administer respiratory medications. They intubate patients, assist with bronchoscopy and other respiratory-related diagnostic tests, perform pulmonary hygiene measures like chest physiotherapy, and serve an integral role during cardiac and respiratory arrests. Social workers. Social workers have a number of different roles in the healthcare environment. They counsel patients and provide psychological support. They liaison with the community in terms of patients' financial needs. They serve as part of the team that ensures care along the continuum of care after the person is discharged, and they sometimes serve as case managers. Psychologists and psychiatrists. Psychologists and psychiatrists provide mental health and psychiatric services to those with psychiatric mental health disorders, both long-term and acute. They also provide psychological support for family members and significant others as indicated. Podiatrists. Podiatrists provide care and services to patients who have foot problems. They often work with diabetic patients to assess the feet to prevent diabetic foot complications. They recommend special footwear. They often clip toenails. And they also treat other non-diabetic patients with disorders of the foot. Prosthetists. Prosthetists, in collaboration with other members of the healthcare team, assess patients and then design, fit, and supply the patient with an artificial body part, such as a leg or arm prosthesis. They also follow up with patients who have gotten a prosthesis to check and adjust it in terms of proper fit, patient comfort, and functioning. Identifying the need for nursing and interdisciplinary client care conference. Healthcare and the provision of healthcare services is highly complex with a vast number of disciplines or professions that contribute to the total care of the patient. For this reason, interdisciplinary or multidisciplinary client care conferences are a highly effective way for all these interacting professions and departments to come together in order to discuss and solve complex patient care problems. The hope is that this collaboration will lead to highly qualified outcomes for the patient. Licensed practical nurses identify patient cases that could benefit from an interdisciplinary client care conference, and they report this need to the registered nurse. They also participate as active members of this conference in addition to the patient, significant others, and members of the healthcare team who are in attendance. Contributing to the development and/or update of the client plan of care. As previously discussed in terms of the nursing process, licensed practical nurses collect data and information about the patient, and they report this data and information to the registered nurse. Some of this data is used to modify and update a patient's plan of care. For example, when the licensed practical nurse observes that the patient is ambulating more frequently and/or for longer distances than the patient normally does, the licensed practical nurse will report this data to the registered nurse. The registered nurse will then modify the plan of care and expected patient outcomes with higher levels of performance in terms of ambulation. Contributing to the planning of interdisciplinary client care conferences. Planning interdisciplinary client care conferences is often challenging. An agenda is developed, information is collected for presentations, healthcare team members are invited, a time, a date, and a room is decided upon, and the client and significant others are encouraged to attend. Licensed practical care nurses are often asked by the registered nurse to help with this planning. Participating as a member of an interdisciplinary team. Participating in groups, including an interdisciplinary client care conference, requires preparation. Therefore, licensed practical nurses should be prepared for these meetings. They should have data and information readily accessible to discuss. They should also have some recommendations for future care that may enhance the client's outcomes of care. In addition to expressing their own thoughts, licensed practical nurses should listen attentively to the thoughts and suggestions of others in a respectful manner and also be able to compromise and negotiate the best plan of care for the patient. Concepts of management and supervision. Many people think that leadership and management are the same thing, but they are not. They are different. Supervision, as discussed somewhat before, is the oversight and evaluation of care, aspects of care, and other nursing functions that have been delegated and assigned to others. Management, on the other hand, is meeting established goals and objectives by planning, organizing, and directing actions and efforts towards established goals. Nurses serve in both management and supervision functions. Recognizing and reporting staff conflict. One of the most upsetting and distressing things that occur when people work together is conflict. One thing that we must understand, however, is that conflict can be beneficial. It is a natural process that will occur and one that cannot be prevented. Conflicts can be beneficial when they are resolved in a healthy, mutually satisfying manner so that all involved in the conflict can win. Licensed practical nurses, therefore, must be able to recognize, identify, and report conflicts so that conflicts do not tatter the team when they are not identified and resolved. Ignoring conflicts will cause problems. Resolving and addressing conflicts can lead to personal and group growth. Simply defined, a conflict is a difference of opinion, beliefs, perspectives, and/or goals that becomes evident and apparent when the symptoms of unresolved conflict occur. Some of these symptoms include arguing, the disruption of work and interpersonal relationships, frustration, criticism of others, and lack of trust and respect for others. The stages of conflict and conflict resolution are: frustration. Frustration occurs when those involved in the conflict believe that their goals and needs are being blocked and not met. Conceptualization. Conceptualization occurs when those involved in the conflict begin to understand what the conflict is all about and why it has occurred. This understanding often varies from person to person, and this personal understanding may or may not be accurate. The conflict continues. Taking action. Those involved in the conflict act. Some act in an active manner. Others act in a passive manner. For example, one person affected by the conflict may act out with anger, hostility, and even physical force. Another may just withdraw from the situation because they simply cannot tolerate the feelings that the conflict evokes. Resolution. Resolution occurs when the group is able to come to some agreement with mediation, negotiation, or another method. This resolution is done with the participation of all of those who are involved in the conflict. Verifying the abilities of staff members to perform assigned tasks. As just discussed, management and the management of care is meeting established goals and objectives by planning, organizing, and directing actions and efforts towards established goals. This goal cannot be fulfilled unless the abilities of staff to perform assigned tasks are verified and the person is deemed competent to perform it. Providing input for the performance evaluation of other staff. Licensed practical nurse can and should provide input to their supervisor relating to the performance of other licensed practical nurses and unlicensed assistive personnel with whom they work. All feedback and performance evaluation should be objective and specific rather than subjective and vague. For example, a statement such as, "The nursing assistant is not properly washing hands between patients," is objective and specific. A statement like, "The nursing assistant is very careless," is subjective and very vague. Participating in staff education. It is the personal, professional responsibility of the nurse to maintain and update their knowledge, skills, and abilities so that quality care can be delivered. Education can be formal or informal, and it can be optional or mandated. For example, Licensed practical nurses should participate in the in-service educational programs that are offered by the employer. They should also complete any state-mandated continuing education that is necessary for relicensure as a licensed practical nurse. Using data from various sources in making clinical decisions. Licensed practical nurses use data to make sound clinical decisions relating to patient care. Some of this data includes assessment data that was collected upon admission and ongoing assessment data. Ongoing assessment data includes things like the results of diagnostic laboratory testing and diagnostic imaging, arterial blood gases, the white blood cell count, the results of an MRI, and the input of the other members of the nursing team and healthcare team in their progress notes and other forms of documentation. Serving as a resource person to other staff. Licensed practical nurse often serve as resource person to another staff member, particularly new staff and new graduates. For example, a new graduate licensed practical nurse or nursing assistant may need the help and guidance from an experienced and skilled licensed practical nurse. Monitoring the activities of assistive personnel. Licensed practical nurses must also monitor the activities of assistive personnel who are helping the nurse in the provision of care. This monitoring and supervision should be ongoing in order to ensure that the correct tasks are being done in the correct and timely manner. Confidentiality and information security. The Health Insurance Portability and Accountability Act, HIPAA. Maintaining client confidentiality and providing for patient privacy. According to the United States Department of Health and Human Services, the Health Insurance Portability and Accountability Act, HIPAA, and the HIPAA Privacy Rule provides federal protections for individually identifiable health information and gives patients an array of rights with respect to that information. At the same time, the Privacy Rule is balanced so that it permits the disclosure of health information needed for patient care and other important purposes such as health insurance reimbursement and quality improvement activities. The security rule of HIPAA has administrative, physical, and technical safeguards to ensure the confidentiality, integrity, and availability of electronic protected health information. This rule relates to electronic information security as well as other forms of information. Our nation's Health Insurance Portability and Accountability Act, HIPAA, protects the patient's rights to the privacy and confidentiality of all medical information, including written and oral electronic information, unless the client has expressly consented to it in writing. Identifying staff actions that impact client confidentiality and intervening as needed. The HIPAA Privacy Rule legally limits access to medical records and information to only those who have a need to know. Those who have the need to know have this need because they need some data and information about the patient so that they can perform some indirect or direct patient care. For example, nurses have a need to know information about the patient so that they can provide the patient with quality care. Dietitians need to know some information about the patient so that they can access and plan care for the patient as based on their nutritional needs and status. Those who provide indirect care, such as the director of nursing, the infection control nurse, the wound care nurse, and the members of the quality assurance department, also have a need to know about patients and groups of patients so that they can perform their roles even though they are not providing any direct patient care to the patient. Others who have a need to know are health insurance companies and students, including student nurses. Licensed practical nurses must be aware of the implications of and the possible consequences for violations relating to the Health Insurance Portability and Accountability Act and the HIPAA Privacy Rule. Nurses should never discuss patients with others who do not have the need to know. They must protect and secure client written records. They must also secure electronic records by protecting and not sharing their password and logging off after each entry. Other things that protect patient privacy and confidentiality include not responding to any telephone or email inquiries about patients unless the inquiring person states a unique identifier for the patient, such as a secret code number or word. Lastly, Facebook and other forms of social media and photos using a cell phone are strictly prohibited. All of these actions impact on client confidentiality. Whenever you witness a breach in terms of this law, you must immediately report it to your supervisor. Recognizing staff member and client understanding of confidentiality requirements. The best way to know whether or not staff members understand and apply the requirements associated with confidentiality and privacy is to observe the staff member as they perform their roles and uphold these rights. For example, is the staff member carrying on idle conversations in the cafeteria about patients? Is the staff member logging off the computer before leaving the screen unattended? Is the staff member securing medical records so that anyone without the need to know has no access to them? Clients must also know their rights and the rights of others in terms of medical information. Nurses can identify a knowledge deficit in this area when a patient asks a nurse a question like, "What is wrong with a patient who is always screaming out?" or similar question. Nurses should inform this inquisitive patient that you cannot share any information with them that relates to other patients. Applying knowledge of facility regulations when accessing client records. All healthcare facilities have regulations, policies, and procedures related to confidentiality and accessing client records. All nurses and other healthcare providers have the responsibility to be knowledgeable about these regulations, policies, and procedures, and adhering to them at all times without any breaches. Maintaining client confidentiality. Few nurses violate patient confidentiality intentionally. It is often momentary lapse of judgment that leads to these breaches, so nurses must consciously think before they act or speak. Providing for privacy needs. Personal privacy, including privacy during visits and during conversations, as well as when they're getting personal care such as hygiene, must also be upheld and maintained. The continuity of care. The continuity of care is the movement of a patient from one level of care to another, from one healthcare facility to another, and from one nursing care unit to another within the same facility. This movement is indicated by the patient's medical status. For example, a patient is moved from a special intensive care unit to a medical surgical unit of a hospital when their medical status no longer indicates the need for intensive care. A patient may be discharged from a hospital to a community-based physical rehabilitation before a return to home because the patient no longer needs the acute care services provided by the hospital. They now need intensive physical and occupational therapy to restore full functioning so that they can then return to home. The nurse, as the manager and coordinator of care, along the continuum of care admits, transfers, and discharges clients. These client movements necessitate communication, collaboration, and cooperation among and between appropriate healthcare team members. Following up with the client after discharge. Healthcare facilities often follow up with patients after discharge to determine the patient's level of satisfaction with the care and services that were provided and to determine the appropriateness of the discharge in terms of the patient's progress after discharge. Participating in client discharge and transfers. Nurses participate in patient discharges and transfers as the senders and receivers of the patient. The sending area communicates with the receiving area to determine whether or not the new area or setting is appropriate for the client. The receiving area determines if the client's needs can be met in the new area or setting according to established admission criteria. All necessary information and medical records are exchanged, after which the client and family are then instructed about the transfer. Providing follow-up on unresolved client care issues. Unresolved issues can never be left unattended. Nurses must report all unresolved issues up the chain of command and communication until resolution occurs. At times, unresolved issues can be followed up by the next shift of nursing team members. At other times, they can be resolved with a simple telephone call. For example, nurses report unresolved issues during the change of shift report. They can also call the patient's doctor when laboratory values reveal significant changes and abnormalities. Providing and receiving report on assigned clients. Reports at the end of a shift ensure a seamless, unfragmented transition from one shift of nursing staff to the next. These handoff or change of shift reports are a critical component of nursing care. These reports must minimally include the patient's name, their doctor's name, the date of admission and diagnosis, all unresolved issues and uncompleted tasks, priorities of care, significant data and information about the patient's status and condition, abnormal diagnostic testing results, the patient's responses to care and treatment, fluid status, including all intake and output, any unusual occurrences, variances, incidents, and accidents, special treatments and patient responses such as the administration of blood, any consults and referrals, and changes in the plan of care and/or doctor's orders. Facilities use standardized methods of reporting to ensure the completeness of these end-of-shift reports as well as patient transfer reports and patient discharge reports. Some standardized change-of-shift handoff reports, as recommended by the Joint Commission of the Accreditation of Healthcare Organization, include SBAR, ISBAR, Baton, the 5 Ps, and IPASS. SBAR stands for S for situation, the patient's diagnosis, complaint, plan of care, and the patient's prioritized needs. B for background, the patient's code or DNR status, vital signs, medications, and lab results. A for assessment, the current assessment of the situation and the patient's status, and R for recommendations, all unresolved issues including things like pending diagnostic testing results and what has to be done over the next few hours. ISBAR stands for Introduction, the introduction of the nurse's role in care, and the area or department that you are from. S for situation, the patient's diagnosis, complaint, plan of care, and the patient's prioritized needs. B for background, the patient's code or DNR status, vital signs, medications, and lab results. A for assessment, the current assessment of the situation and the patient's status, and R for recommendations, all unresolved issues including things like pending diagnostic testing results and what has to be done over the next few hours. Baton stands for B for background, past and current medical history including medications. A for actions, what actions were taken and/or those actions that are currently required. T for timing, priorities and level of urgency. O for ownership, who is responsible for what, and N for next, the future plan of care. The 5 Ps are P for patient, the patient's name, age, gender, location, and other demographic data. P for plan, patient diagnosis and plan of care. P for purpose, the rationale for the care plan. P for problems, things that are different, abnormal, or unusual. And P for precautions, risks and things that may change and/or become unusual for the patient. IPASS stands for Introduction, the introduction of the nurse's role in care, and the area or department that you are from. Patient, the patient's name, age, gender, location, and other demographic data. A, the current assessment of the situation and the patient's status. S, situation, the patient's diagnosis, complaint, plan of care, and the patient's prioritized needs. And safety concerns, physical, mental, and social risks and concerns. Recording client information in the medical record and on various forms. A wide variety of documentation forms exist. Some of these forms include progress notes, admission forms, transfer forms to another level of care or service, referral forms, discharge forms, daily care flow sheets, graphic charts for vital signs, blood glucose level forms, intake and output forms, assessment forms, falls risk and skin breakdown assessment forms, narcotic records, patient teaching records, and other documents that are primarily used by other disciplines such as laboratory and diagnostic imaging reports. Using agency guidelines to guide client care. Regardless of the differences among healthcare facilities in terms of the provision of care along the continuum of care and their specific documentation methods and forms, nurses must follow their own facility's policies, procedures, and guidelines. For example, some facilities use problem-oriented charting, and others may use source-oriented medical records. Some may use multidisciplinary critical pathways, or care maps. Others may use discipline-specific care plans, like nursing care plans. Establishing priorities. Organizing and prioritizing care for an assigned group of clients. As previously mentioned, priorities are established using a number of methods and frameworks, including the ABCs, Maslow's hierarchy of needs, and the ABCs MAA-UAR method. The ABCs identify the airway, breathing, and cardiovascular status of the patient as the highest of all priorities in that sequential order. Maslow's hierarchy of needs identifies the physiological or biological needs, including the ABCs, the safety, psychological, emotional needs, the need for love and belonging, the needs for self-esteem and the esteem by others, and the self-actualization needs in that order of priority. Some examples of each of these needs according to Abraham Maslow's hierarchy of needs are physical and biological needs. Some physical needs include the needs for the ABCs of airway, breathing, and cardiovascular function, nutrition, sleep, fluids, hygiene, and elimination. Safety and psychological needs. The psychological or emotional, safety, and security needs include needs like low-level stress and anxiety, emotional support, comfort, environmental and medical safety, and emotional and physical security. Love and belonging. The love and belonging needs reflect the person's innate need for love, belonging, and the acceptance of others, including a group. Self-esteem and esteem by others. All people have a need to be recognized and respected as a valued person by themselves and by others. People have a need for self-worth and self-esteem. They need the esteem of others. Self-actualization. Self-actualization needs motivate the person to reach their highest level of ability and potential. The ABC's MAA-UAR method, which was previously detailed, places the ABCs as the highest and greatest priorities. These are then followed with the second and third priority level needs. The second priority level needs include MAA-UAR, which is mental status, acute pain, acute impaired urinary elimination, resolved and unaddressed needs, abnormal diagnostic test results, and risks. The third level priorities include all concerns and problems addressed with the second level priority needs. Participating in planning client care based upon client needs. Nurses and other members of the healthcare team collaboratively organize and prioritize patient care priorities as based on the client's needs, the client's diagnosis, their strengths and their weaknesses, their medical and nursing diagnosis, their abilities, their prescribed treatments, and client preferences. At times, the client's priorities may differ from that of the nurse or another member of the healthcare team. Because the client is the center of care, priorities are often negotiated with the client in order to identify and determine mutually decided upon priorities of care. Using effective time management skills. Time is finite, and patient needs are often infinite. Nurses must prioritize and reprioritize according to the changing needs of the patient and the group of patients that is receiving nursing care. In addition to prioritizing and reprioritizing, nurses should have a plan of action to effectively manage their time. They should avoid unnecessary interruptions, time wasters, and helping others when this could jeopardize their own priorities of care. Ethical practice. Ethics, simply defined, is a principle that describes what is expected in terms of right and correct and wrong or incorrect in terms of behavior. For example, nurses are held to ethical principles contained within the American Nurses Association Code of Ethics. Ethics and ethical practice are integrated into all aspects of nursing care. The two major classifications of ethical principles and ethical thought are utilitarianism and deontology. Deontology is the ethical school of thought that requires that both the means and the end goal must be moral and ethical. The utilitarian school of ethical thought states that the end goal justifies the means, even when the means are not moral. The ethical principles that nurses must adhere to are the principles of justice, beneficence, non-malfeasance, accountability, fidelity, autonomy, and veracity. Justice is fairness. Nurses must be fair when they distribute care, for example, among the patients in the group of patients that they are taking care of. Care must be fairly, justly, and equitably distributed among a group of patients. Beneficence is doing good and the right thing for the patient. Non-malfeasance is doing no harm, as stated in the historical Hippocratic Oath. Harm can be intentional or unintentional. Accountability is accepting responsibility for one's own actions. Nurses are accountable for their nursing care and other actions. They must accept all of the professional and personal consequences that can occur as a result of their actions. Fidelity is keeping one's promises. The nurse must be faithful and true to their professional promises and responsibilities by providing high-quality, safe care in a competent manner. Autonomy and patient self-determination is upheld when the nurse accepts the client as a unique person who has the innate right to have their own opinions, perspectives, values, and beliefs. Nurses encourage patients to make their own decisions without any judgments or coercion from the nurse. The patient has the right to reject or accept all treatments. Veracity is being completely truthful with patients. Nurses must not withhold the whole truth from clients even when it may lead to patient distress. The most commonly occurring ethical issues and concerns in healthcare include the allocation of scarce resources and end-of-life issues. Bioethics is a subcategory of ethics. Bioethics addresses ethical concerns like those that occur as the result of advancing science and technological advances. Some of the most common current bioethical issues revolve around stem cells, cloning, and genetic engineering. Identifying ethical issues affecting the staff and/or a patient. Nurses have the responsibility to identify ethical issues that affect staff and patients. For example, providing nursing care for clients undergoing an abortion may raise ethical and moral concerns and issues for some nurses. Some patients may be affected with a liver transplant rejection because donor livers are not abundant enough to meet the needs of all patients who request it. Many hospitals, medical centers, and other healthcare facilities have multidisciplinary ethics committees that meet and resolve ethical dilemmas and conflicts. Informing the client of ethical issues affecting client care. A patient may, at times, ask you to do something that is not ethical. For example, a patient may ask a nurse to assist in their suicide at the end of their life, or they may inquire about another patient in terms of their diagnosis. When something like this occurs, the nurse must inform the client that they cannot do it for ethical and legal reasons. Intervening to promote ethical practice. Nurses must intervene and report any unethical practices. They must also promote ethical practice. In summary, the steps of the ethical decision-making process are: 1. Problem definition. The nurse defines the ethical dilemma, the circumstances, and the situation. 2. Data collection. Data and information relating to the ethical dilemma and problem are collected and organized. 3. Data analysis. Data and information are analyzed. 4. Generating possible solutions. All possible alternatives and solutions, in addition to their possible implications and consequences, are considered. 5. Selecting the best possible solution. The best of all the possible solutions and alternatives is selected as based on the principles of morality and ethics. 6. Implementing the selected action. 7. Evaluating the results and outcomes of the action. Were the means and the end both ethical and moral? Were all professional resources utilized to resolve the ethical dilemma or concern? Practicing in a manner consistent with the Code of Ethics for Nurses. The American Nurses Association's Code of Ethics applies to all nurses, in all diverse roles, and in all healthcare settings. The American Nurses Association's Code of Ethics emphasizes the dignity and worth of all people without discrimination, the nurse's commitment to patients, the provision of quality care, collaboration, the integrity of the nursing profession, advocacy, accountability, the preservation of safety, patient rights such as dignity, autonomy, and confidentiality, competency, and the resolution of ethical dilemmas and/or conflicts. Reviewing client and staff members' knowledge of ethical issues affecting client care. The best way to determine whether or not staff and patients have knowledge of ethics and ethical issues that affect patient care is to observe the actions and behaviors that indicate that the person is applying ethics, ethical principles, and the American Nurses Association's Code of Ethics. Informed consent. Informed consent is defined as the patient's election of a treatment or procedure which is based on their full understanding of the treatment or procedure, its benefits, its risks, and any alternatives to the particular treatment or procedure. All clients have the legal right to autonomy and self-determination to accept or reject all treatments and interventions. With the exception of emergencies, all aspects of nursing care and interventions must be explained to the patient. When legal informed consent is not given by the patient, treatments and procedures that are done without consent are considered illegal, assault, and battery. There are three basic types of consent. These types of consent are implicit consent, explicit consent, and opt-out consent. The implicit or implied consent is indirect rather than formal and direct. For example, a patient gives implicit consent to nursing care when they agree to and consent to hospitalization. Explicit consent, in contrast to implicit consent, is direct and often formal as well as documented. For example, an informed consent for surgery is done in writing. It is documented and entered into the patient's medical record. Opt-out consent is passive and indirect. This type of consent is given when a patient does not refuse a treatment. The lack of objections by the patient indicates that the person has consented to the treatment or procedure with an opt-out consent. Identifying the appropriate person to provide informed consent for the client. Informed consents can only be obtained from an adult patient who is mentally competent to do so. When consent, for any reason including the lack of majority, mental incompetence, and unconsciousness, cannot be obtained, other people can provide legal consent for the patient. Some of these people are a legally appointed representative for a developmentally disabled adult, for example, the parent or legal guardian of a minor child, an emancipated minor who is independent of their parents, and the durable power of attorney for healthcare decisions or the healthcare surrogate or proxy. Participating in the client consent process. The physician or other licensed independent provider, the nurse, and the client have roles and responsibilities in terms of informed consent. The nurse is responsible and accountable for the verification of and witnessing that the patient or the legal representative have signed the consent document in their presence and that the patient or the legal representative is of legal age and competent to provide consent. They also confirm that the patient has sufficient knowledge to make a knowledgeable decision. The physician provides the client with complete information about the treatment or procedure, the potential risks, including pain and complications, the benefits of the treatment or procedure, who will perform the planned treatment or procedure, and any possible alternatives to the treatment or procedure, including the benefits and risks. The patient, or their legal representative, must give consent voluntarily and without any coercion by others. They must also ask questions and clarify things until they are certain about the procedure, the benefits, the risks, and possible alternatives. The requirements of informed consent. The components of informed consent, as discussed immediately above, include the provision of complete and unbiased information about the treatment, the purpose of the treatment, the risks, benefits, who will perform the proposed treatment or procedure, alternatives, and options. Additional components include the verification that the client fully understands this information and their right in terms of refusing the treatment or procedure. Recognizing that informed consent was obtained. The recognition that informed consent was obtained is based on the legality and completeness of the written consent and the required process for obtaining a consent, including the client's legal ability to sign it and the client's understanding of the procedure or treatment that they are consenting to. There are times, such as during the preoperative period, that nurses must recognize, identify, and confirm that a complete surgical consent was obtained and placed in the patient's medical record. Information technology, IT, simply defined, is the use of computers, telecommunication, and other electronic technological advances to store data that may be preserved and protected, to transmit data and information to others, and to be able to retrieve and use it for a purpose such as reimbursement and research. Information technology is a double-edged sword. Information technology is of great benefit to healthcare, healthcare agencies, healthcare providers, and patients, but it is not without its perils and pitfalls. Some of the risks and perils of information technology include utility failures that prohibit the use of this technology, breaches of patient privacy and confidentiality, computer hacking, and crashes that delete data. Using information technology in client care. Information technology has endless possibilities for use in terms of patient care and healthcare. Some of these uses include barcodes with unique patient identifiers to avoid medical errors secondary to the poor identification of a patient before treatments, including medication errors and wrong procedure errors. Barcodes that can be used for the billing of patient care supplies and equipment. Electronic medical records. Automated doctors' ordering systems. The ready access to facility policies and procedures. The collection and analysis of performance improvement and risk management data, as well as the ready retrieval of pertinent information from the Internet like professional databases, journals, educational programs, best practices, evidence-based practices, and reliable patient and family education materials. Accessing data for clients and staff using online databases and journals. Technology has given nurses tremendous opportunities to research and explore data and information that is useful for staff and for client care. One of these opportunities is the exploration and use of evidence-based practice. Entering computer documentation accurately, completely, and in a timely manner. Whether or not computers are used or hard copy documents are used, all documentation, as previously discussed, must be professional, complete, accurate, and timely. Receiving and/or transcribing healthcare provider orders. Again, whether or not computers are used or hard copy documents are used for healthcare provider orders, nurses have to ensure that the order is complete and appropriate. All questionable orders must be followed up on by the nurse with the ordering healthcare provider. Legal responsibilities. Some of the legal terms that you must be familiar with include these. Common law. Common law is law that results from previous legal decisions. They are based on legal precedent. Berman and Snyder, 2012. Statutory law. Statutory law is law that is passed by a legislative body such as the state's legislature or the U.S. Congress. Berman and Snyder, 2020. Constitutional law. Constitutional law is law that is included in the Constitution of the United States of America and its amendments. Berman and Snyder, 2012. Administrative law. Administrative law is rules and regulations that are legally enacted to support some statutory law. For example, nursing boards enact administrative rules and regulations relating to state-enacted laws such as the State's Nurse Practice Act and legislated continuing education requirements for the relicensure of nurses. Berman and Snyder, 2012. Criminal law. Criminal law, part of public law, covers acts that are illegal and against the law. Criminal law includes felony and misdemeanor infractions of the law. Berman and Snyder, 2012. Civil law. Civil law, also part of public law, covers torts and contract laws. Berman and Snyder, 2012. Torts. Torts are civil laws that address the legal rights of patients and the responsibilities of the nurse in the nurse-patient relationship. Some torts specific to nursing and nursing practice include things like malpractice, negligence, and violations relating to patient confidentiality. Berman and Snyder, 2012. Unintentional torts. Unintentional torts include things like malpractice and negligence. Intentional torts. Intentional torts include things like false imprisonment, assault, battery, breaches of privacy and patient confidentiality, slander, and libel. Liability. Liability is vulnerability and legal responsibility, simply stated. For example, nurses are liable when they fail to carry out doctor's orders. Berman and Snyder, 2012. Respondeat superior. Respondeat superior is the legal doctrine or principle that states that employers are legally responsible for the acts and behaviors of its employees. Respondeat superior does not, however, relieve the nurse of legally responsibility or accountability for their actions. They remain liable. Berman and Snyder, 2012. Negligence. Negligence is a non-intentional tort. Negligence occurs when the nurse fails to follow established policies, procedures, and standards of care in the same manner that another reasonable nurse would do in the same situation. Berman and Snyder, 2012. Malpractice. Malpractice, also a non-intentional tort, has 6 elements. The elements of malpractice include a duty, a breach of duty as a nurse, reasonable foreseeability that the nurse's act has a connection with the patient injury that occurred, the patient was harmed, the link that act directly led to the harm, and the patient has the right to financial compensation or damages. Berman and Snyder, 2012. Assault. Assault, an intentional tort, is threatening to touch a person without their consent. Berman and Snyder, 2012. Battery. Battery, another intentional tort, is touching a person without their consent. Berman and Snyder, 2012. False imprisonment. False imprisonment is restraining, detaining, and/or restricting a person's freedom of movement. Using a restraint without an order is considered false imprisonment. Berman and Snyder, 2012. Defamation. Defamation is making false statements about a person in writing or orally that leads to the destruction of a person's reputation. Berman and Snyder, 2012. Slander. Slander is oral defamation of character. Berman and Snyder, 2012. Libel. Libel is written defamation of character. Berman and Snyder, 2012. Identifying legal issues affecting staff and clients. Some of the most commonly occurring legal issues that impact on nursing and nursing practice are those relating to licensure, malpractice, negligence, mandatory reporting, informed consent, and accepting an assignment. Licensure. All registered and licensed practical or vocational nurses must be currently licensed to practice nursing in their state of practice. Licensure protects the consuming public and ensures that the nurse has completed a state-approved nursing school, has successfully passed their licensure examination, and has also continuously met the requirement or requirements for relicensure each biennium without any suspensions or revocations of their license. Practicing without a current and valid license is illegal. It amounts to practicing without a license. Malpractice. Malpractice is an act of omission or commission that does not meet established standards of care and causes some injury to the patient, as just discussed. Negligence. Negligence is also an act of omission or commission that does not meet established standards of care. It differs from malpractice because it lacks one or more of the 6 elements of malpractice that are essential to be considered malpractice. Now, let's talk about documentation, which was previously detailed. Mandatory reporting. Nurses are legally mandated to report abuse, neglect, gunshot wounds, some communicable diseases, and any unsafe and/or illegal practices by another healthcare provider. Informed consent and refusals of treatment was fully detailed previously. The acceptance of assignment. Nurses are legally accountable to accept only those assignments that are appropriate in terms of their Nurse Practice Act and scope of practice, and only those that the nurse believes that they are competent to perform. Receiving and processing provider orders. Nurses are responsible for receiving and processing physician-provider orders. Some of the specific aspects of this responsibility include the nurse's review of an order for completeness, questioning orders that a patient questions, questioning orders that do not seem to be appropriate for the patient, and questioning orders that are incomplete, illegible, and/or not clear. Telephone orders and other verbal orders are strongly discouraged. They can lead to serious errors. When it is necessary to call a provider to get an order, the nurse must fully document the order and the circumstances that necessitated the telephone order. The nurse will then read the order back to the ordering physician to confirm its correctness. Some facilities also require that 2 nurses hear and confirm the order. Recognizing tasks and assignments that you are not prepared to perform and seeking assistance. As previously discussed with the assignment of care, nurses should never accept an assignment that is outside of their scope of practice or they are not prepared to do. When you do not believe that you are competent to do a task or assignment, you cannot accept it. You must report this problem and seek the assistance of the supervising nurse. Responding to the unsafe practice of a healthcare provider. Similar to responding to and reporting unethical practice, illegal or unsafe practices of other healthcare providers must also be reported when you suspect it. You should also stop it if you see it. Following regulations and practices for reporting specific issues. As mandated reporters, nurses are legally mandated to report abuse, neglect, gunshot wounds, other deadly injuries, some communicable diseases, and any unsafe and/or illegal practices by another healthcare provider. When these circumstances occur, the nurse must follow their facility's policies and procedures in terms of documentation and reporting. Documenting client care. As previously discussed, all medical records are legal documents that must be managed and maintained in a legal manner. Documentation must be complete, timely, accurate, and professional. Providing care within the legal scope of practice. Licensed practical nurses must be aware of their state's Nurse Practice Act and their scope of practice. It is considered illegal and practicing nursing without a license when the nurse does not adhere to these legal regulations. Performance improvement, quality improvement, and risk management. Identifying the purpose and impact of performance improvement, quality improvement activities on client care outcomes. Over the last several years, the measurement of quality has changed and evolved. Measuring quality has moved from quality control to quality assurance, and now to quality improvement and performance improvement. The focus of these activities has also moved from studying structures like policies and procedures to studying processes, and now to studying and measuring outcomes in terms of the patient. Performance improvement activities improve and enhance the outcomes of care. They improve the safety and efficiency of processes. They can also reduce costs and liability. Outcomes will be unpredictable and erratic when processes and the structures are not stable. Unstable structures and processes lead to unstable, unpredictable, and erratic outcomes. The ultimate goal of performance improvement activities is to achieve and sustain high-quality outcomes. So, stable and appropriate structures and processes must be in place before outcomes can be of high quality and sustained over time. The Joint Commission on the Accreditation of Healthcare Organizations, JCAHO, the Centers for Medicare and Medicaid, CMS, and our state's Departments of Health require that all healthcare facilities conduct performance improvement activities. Some healthcare facilities have separate quality assurance departments. Other healthcare facilities may simply delegate these responsibilities to one or more people in the facility. Healthcare facilities should establish their performance improvement priorities on concerns and opportunities for improvement that are the greatest risk, the greatest volume, the highest costs, and the most problem-prone. Participating in quality improvement QI activities. Nurses participate in quality improvement activities as part of a team. A team is a group of people who work together to achieve a common goal. Teams have a shared mission that all members of the team are committed to. Teams use a variety of interconnected and interpersonal processes. They have accessible data and information to perform their role, and they produce outcomes. All members of the team must be able to communicate with the other members in a respectful, trusting, open, thoughtful, cooperative, and mutually supportive environment. All must be willing to confront issues, including conflicts. They must feel free to express their thoughts, perspectives, and opinions in an open manner without any fears of judgment by others. Teams are essential to the healthcare organizations, particularly when the organization is identifying and attempting to solve quality issues and concerns. Teams have collective wisdom. Teams have collected wisdom and the ability to perform much more than an individual alone. Teams are synergistic and very powerful. The whole is greater than the sum of its parts. Although teams, when well managed and maintained, can be highly beneficial to the healthcare organization, there are some disadvantages. One obvious disadvantage is the fact that the team decision-making is more time-consuming than solitary decision-making. Multidisciplinary teams are teams that maximize the many and diverse skills associated with the different healthcare disciplines. Each member of the multidisciplinary team has their own abilities and skills that they use to focus on different problems as they apply this expertise. One of the major benefits of groups in healthcare is the fact that those closest to the processes at hand and most aware of the problems are included. Management is often not as aware of these process problems because they are so far removed from the front line. Your participation in quality improvement necessitates your ability to be flexible, dependable, competent, prepared, adaptable, self-disciplined, focused, motivated by the mission and goals of the group, committed to the group and its work, and able to add value to the group. Group members must also be able to effectively collaborate with others, to communicate with others, and to develop and maintain good working relationships. After a problem or an opportunity for improvement is identified, the performance improvement process begins with the identification of standards. Standards reflect the minimal expectations and measurable criteria, or indicators, relating to patient safety and high-quality care. Some of these standards are generated by law. Some are generated by professional organizations. Some are developed by external regulatory bodies like the Joint Commission on the Accreditation of Healthcare Organizations, JCAHO. Still more are developed by the specific healthcare organization and found in their policies and procedures. The primary purposes of these standards are to ensure the safety of the consuming public, to guide nursing care, and to serve as criteria against which quality can be measured and determined. The next steps of the performance improvement process, in sequential order, are 1. The collection of data. 2. The analysis of data. 3. The comparison of data to established standards of benchmarks. 4. Root cause analysis to dig down to the possible causes of the problem. 5. Generating a list of possible solutions to the problem. 6. Collecting the solution that has the best possibility of success. 7. Implementing the best solution. And then finally, 8. Measuring the effectiveness of the implemented solution. Performance improvement and risk management activities must be conducted in a blame-free environment in order for these activities to be effective. When issues and problems arise, they should be viewed as opportunities for improvement and not opportunities to find and punish the person who erred or made a mistake. Processes should be fail-proof and not subject to human error. Therefore, many performance improvement activities focus on improving processes to make them fail-proof and not subject to human error. Root cause analysis is a performance improvement process that is used to dig down to the deepest, real reasons why mistakes and errors have occurred. These reasons are usually procedures and processes and not people. Root cause analysis occurs in a blame-free environment with teams that analyze faulty processes with a number of techniques such as brainstorming, flowcharting, fishbone diagrams, and statistical data analysis. It is recommended that all sentinel events are examined using root cause analysis. A sentinel event is an occurrence that leads to, or has the potential to lead to, an adverse outcome. Even near misses are sentinel events. The processes that cause harm as well as those that lead to near misses must be refined and improved so that all possible human errors are eliminated. That way, future sentinel events can be prevented. An example of a sentinel event that leads to harm is a fall that has resulted in patient injury. Examples of near-miss sentinel events include a nurse discovering that the wrong patient was almost sent to the operating room, and when the nurse realizes that they almost gave a patient the wrong dosage of an ordered medication. Some of the most commonly occurring medical error sentinel events include medication errors, the unintended retention of a foreign body after surgery or other invasive procedure, wrong patient, wrong site, wrong procedures, treatment delays, suicide, operative and post-operative complications like infections, falls, and other unanticipated events. Tables, charts, and graphs are a fabulous way to display performance improvement and risk management data for reports and during group discussions. Some of the most commonly used tables, graphs, and charts are cause and effect diagrams, also referred to as a fishbone or Ishikawa diagram, check sheets, Pareto charts, scatter diagrams, control charts, histograms, stratification charts, also referred to as a flow chart or a run chart, pie charts, bar graphs, and line graphs. Nurses are very often asked to work on a performance improvement activity. For example, they may be asked to serve on a performance improvement committee or another small group. They may be asked to collect data. They may be asked to help with the analysis of data. They may be asked to participate in a root cause analysis activity. Documenting performance improvement, quality improvement activities. All aspects of performance improvement and quality improvement activities must be documented. Concerns and problems are reported orally or in writing on perhaps an accident or occurrence report. Minutes of committee and group meetings are recorded. Root cause analysis is documented. And corrective action plans are documented and tracked over time. Reporting identified client care issues and problems to appropriate personnel. Nurses must immediately report a client care issue, concern, or problem to the supervising nurse, the charge nurse, and/or the performance improvement or risk management department according to the reporting policies and procedures of the particular facility. This required reporting includes the reporting of sentinel events that may or do actually lead to harm. Often, sentinel events are documented and reported on the facility's incident or accident report. Applying evidence-based practice when providing care. Evidence-based practice is research-based practice. The Joanna Briggs Institute tells us that evidence-based practice focuses on the need of health professionals to base their interventions and activities on the most up-to-date evidence or knowledge available. The evidence-based approach acknowledges the difficulties faced by busy practitioners in keeping up to date with an ever-growing literature in healthcare and emphasizes the importance of providing them with condensed information gathered through the systematic review of the international literature on a given topic. The source is http://www.joannabriggs.edu.au/about/jvi_model.php. The Joanna Briggs Institute is a not-for-profit international research and development agency based in Adelaide, South Australia, that advances evidence-based practice by improving the feasibility, appropriateness, meaningfulness, and effectiveness of healthcare practices and healthcare outcomes by facilitating international collaboration. The Joanna Briggs Institute has readily available evidence-based protocols, best practices, consumer information, and evidence-based practice recommendations such as those in the area of aged care, oncology, burns, chronic diseases, medical care, surgical care, infection control, and rehabilitation. For example, some of the evidence-based practice recommendations relating to aging care include, among many others, advanced care planning and admission criteria for residential aged care. The referral process. Recognizing the needs for referrals and obtaining necessary orders. Nurses must recognize and identify the need for referrals and obtaining necessary orders to meet the needs of the patient in terms of their actual and potential healthcare problems. For example, A client who is admitted to your hospital or medical center with a hemorrhagic cerebrovascular accident may need referrals for physical therapy, occupational therapy, and even speech therapy to assist with communication and swallowing disorders that may have occurred as a result of this neurological injury. A resident in your long-term care facility may need a referral to a wound care nurse when the skin integrity is being disrupted because of incontinence and/or immobility. Some referrals are made to resources within the facility. Other referrals are made to community resources external to the healthcare facility. Some referrals, like a referral for home care and a referral to a community physical therapy office, need an order from the doctor or another licensed independent practitioner. Referrals are often necessary to ensure that the patient is moving to a level of care with the appropriate resources along the continuum of care. The nurse, as the patient advocate and the coordinator of care, participates in the referral process. The steps of the referral process are collecting data, analyzing data, discussing possible referrals with the patient, and then completing the referral process. All pertinent and significant data and information is collected. Some of this data includes the current biopsychosocial assessment and status of the client, their social supports, their economic and health insurance status, and the patient's choices. Data is analyzed to determine the needs of the patient's strengths, and the patient's weaknesses. For example, is the client able to drive to or get transportation to a community-based physical therapy office? Nurses will then discuss possible referrals with the patient to determine which of the alternatives the patient would like to pursue. As always, patients can choose their own options. Necessary orders for the referral are then obtained from the patient's doctor. Identifying community resources for the client. Common referral needs include resources and/or assistance including those related to transportation, meal preparation such as Meals on Wheels, parenting resources, child daycare, psychological support, financial support, physical, occupational, and speech therapies, respite for caregivers, emergency housing and shelter, crisis intervention, and elder care and elder daycare. Identifying and using appropriate documents when referring a client. All nurses in healthcare facilities that refer a patient to a receiving healthcare provider or health-related facility provide the receiver with all the necessary information and patient data. This way, they can provide the care and services according to that data and information. Participating in client data collection and referrals. Some facilities use a special referral form to transmit and provide the receiver with this data. Some receiving agencies require additional specific data, and information is collected at your facility prior to seeing the patient. Nurses often participate in collecting this data and documenting it on the agency's forms in addition to participating in other stages of the referral process, such as participating in a multidisciplinary patient care conference to plan the patient's discharge and/or necessary patient referrals. Resource management. Resource management and resource allocation are essential to the provision of care that is justified by medical need, appropriate, efficient, and consistent with the guidelines and criteria that are established with third-party payers, including Medicare and Medicaid. Utilization review includes identifying things like the need for medical services in terms of daily visits, operative procedures and/or assessments, and orders for treatment which justify the patient's stay in an acute care facility. The need for nursing care because professional decision-making and complex treatments justify acute care, and the patient's unstable, unpredictable, biopsychosocial needs and conditions. Resource management and the utilization of healthcare services is very closely aligned to the proper movement of a client along the continuum of care from one level of care to another as based on and justified with the patient's current needs without compromising quality and positive patient outcomes. Pre-admission insurance authorization, also known as the admission certification, and concurrent authorizations during the patient's length of stay are based on medical necessity and the current and documented needs of the client. These authorizations are approved as the direct function of the client's level of acuity, needs, and the necessity of medical care at a level that is appropriate for the patient. Ideally, and in most cases, the pre-admission certification and concurrent authorizations are obtained, but at times this is not the case. When certifications and authorizations are not obtained, the healthcare facility at the administrative level may appeal the denial. Many cases of denial occur as the result of poor and incomplete documentation. So, for this and many other reasons, documentation must be complete. Insurance reimbursement denials jeopardize the financial status of healthcare facilities. As is often stated, if it was written, it was not done. Recognizing the client's need for supplies, materials, and equipment. Patient needs vary in terms of the supplies, material, and equipment that are necessary to provide care and services in the best possible and least costly manner. Medicare, Medicaid, and private insurance companies need a justification for the rental or purchase of reusable medical equipment, such as walkers, wheelchairs, prostheses, oxygen equipment, suctioning equipment, and single-patient use disposable supplies, such as personal protective face masks and wound dressing supplies. A certificate of medical necessity must be submitted by the client's independent practitioner, such as a medical doctor, physician's assistant, or nurse practitioner, for these supplies and equipment. The medical supplies and durable medical equipment will be provided and reimbursed for by the insurance company only when this certificate of medical necessity reflects the fulfillment of their established criteria for reimbursement. Similar to durable medical equipment and disposable supplies, support devices and pharmaceuticals, including medications, are only covered and reimbursed when there is documented evidence of medical necessity for these services. Some of the support services that are reimbursed for, as based on actual need, include the services of occupational therapists, speech and language therapists, physical therapists, and home health care after the patient is discharged from the hospital. Reviewing the effective use of client care materials by assistive personnel. In the past, hospitals were reimbursed for all of the care and services that were provided to patients regardless of medical necessity. This form of reimbursement was called retrospective reimbursement. For example, hospitals were reimbursed for questionably necessary diagnostic tests, they were reimbursed for questionably necessary treatments, and they were reimbursed for questionably necessary lengths of stay. With this retrospective reimbursement system, there was little or no reason to contain costs because insurance companies paid for all services regardless of costs and their medical necessity. As healthcare costs increased and spiraled out of control, cost containment became necessary. This necessity gave rise to prospective reimbursement and the eradication of retrospective reimbursement. With prospective reimbursement, the healthcare organization is reimbursed a fixed rate that is attached to the patient's diagnosis-related groups, which is referred to as the DRG. With prospective reimbursement, healthcare organizations were challenged with the ability to continue to provide high-quality care with less money. Everything after admission is overhead that cuts into the money that the healthcare facility gets from insurance companies, including Medicare and Medicaid. Reimbursement became very limited, and these limitations continue to challenge us today. The implications of prospective reimbursement are vast for nurses, other healthcare providers, and healthcare organizations. Nurses must conserve time and resources. They must also ensure that they, as well as others like assistive supportive personnel, are conserving and limiting the use of treatments, procedures, and supplies. They must also prevent complications because the complications of hospitalizations and treatments waste money and prolong the lengths of stay for patients, both of which cut into the healthcare facility's revenue. They must also prevent complications because the complications of hospitalizations and treatments waste money and prolong the lengths of stay for patients, both of which cut into the healthcare facility's revenue. Safety and infection